All right, welcome to today's program. Your line was muted upon entry to the meeting and will only be unmuted if you have been called upon to speak. To ask a question during this talk, please use the Q&A box in the lower right-hand corner of your screen. You will hit the caret icon to expand the section. For any comments or assistance with the meeting, please use the chat feature, which can be found by clicking on the chat icon in the presentation window. Please direct your question to all panelists. I will now pass the floor over to the moderator. Jody, you now have the virtual floor. All right, Jody, you are on mute if you are trying to speak. Jody, are you for us?
Hello, we'll try that again. Good afternoon, everybody, and welcome to our Webinar Wednesday series. Thank you so much for joining. We're looking forward to a great session here this afternoon in regards to optimizing lung cancer care and building a lung health program. And with us today, we have some excellent speakers who have done amazing work in this area. And I know they're anxious to share their experience and bring the materials and information to you, allow you to ask questions and really dig into this great opportunity today. Moderating our session will be Dr. Bobby Mahajan, who's Medical Director at Inova Fairfax, leading a great lung health program there. Dr. Greg Lemens, he's an interventional pulmonologist at Bozeman Health Pulmonary Medicine, and he as well just started a wonderful program that's been underway here since he's been a part of that initiative. And Dr. Bill Mayfield, thoracic surgeon, head of surgical area there at Wellstar Health Center in Atlanta, Georgia. And again, very excited to bring these speakers with you today to bring you on the journey of what they have done in order to get their lung programs off the ground. In just a second, I'll hand this over to Dr. Mahajan to kick this off. But I did want to say throughout the session, we will show these QR codes a few times. It'll allow you the opportunity to just take your camera on your phone, aim it at the QR code, and it will launch a survey. And we're anxious to get some feedback from you as we conduct these sessions once a month, and would love to understand what needs and areas of opportunity you believe would be best for us to continue to focus on. So with that, we look forward to getting started. And Dr. Mahajan, the floor is yours.
All right, thank you so much, Jody. I appreciate everyone's willingness to come on in at 5 o'clock your time, 6 p.m. our time, and we have the opportunity to talk to two great physicians, Dr. Greg Lemens and Bill Mayfield. And part of what we want to do today is not just talk about the parts of a lung health program. Really what we want to kind of emphasize is it's not only a benefit to do these programs, not only for patient care, but also to continue to build the programs further and further to spread out to your community and allow that not only the patients benefit, but also your hospitals and community benefit as a whole. So really what I want to talk about is a few things. First, I want to just kind of show some of my, try and move through here, disclosures, really Medtronic, Boston Scientific, Pulmonx, Circulogene. These are really what we kind of speak for, but really I'll be focusing on some of the Medtronic aspect today. For optimizing a lung health program, what I want to talk about more than anything else is what these two gentlemen have already done in terms of organizing programs as opposed to just doing volume. And really one kind of paragraph I look at and I've talked about quite a bit is a lung health program can either be a group of individuals who work independently to take care of patients. And don't get me wrong, that's an important part of medicine. It's an important part of thoracic surgery, pulmonary, interventional pulmonary, and oncology. But really what we strive to do is look at for a lung health program is a group of like-minded individuals who work synergistically to improve patient care. Now, that might sound very kind of basic, but if you break it down a little bit further, what we end up seeing with especially interventional pulmonologists and thoracic surgeons is that when we first come out to build programs and we move to different areas, either hospitals have already had a program that say we've always done it this certain way, how do we expand on what we already have, versus hospitals where a new individual is coming into that space and saying, look, this is what my vision is. A lot of times what we get saddled with is the idea of, well, hospitals want us to do volume. They want to see cases, and they want to see numbers where a patient went from, or a physician went from 0 cases to 200 cases in a very short amount of time. And the reason we look at that is because it's one of the few metrics we can try and focus on when it comes to program growth, right? Unfortunately, when you look at individuals who are doing multiple procedures or surgeries at one time, it really isn't cohesive anyway. It's individuals who are looking out for their own growth, and the only metric they can use is either an RVU or a case that they did, right? And that inherently develops competition between practitioners, between administrators, and honestly between hospitals in the same system, to the one point where hospitals are working independently in different silos, right? Whether, as opposed to just doing high volumes by individuals, by trying to put together improved patient care instead of procedures, we start seeing program growth. Okay, and the reason I bring this up is it's something I've realized only in the last 6 years, in the sense that when I first got to Inova Fairfax, there was really kind of a pulmonary desert when it came to interventional pulmonology in the Northern Virginia area. And I got there, and their perspective was, all right, Bobby, do a bunch of cases. We want to see the volume grow. And volume is great when you're doing only volume. But if you're not connecting those cases together, putting infrastructure together, you're really not improving patient care. You're just doing diagnostics or therapeutics. And what we were able to see is, after my first 3 years of doing just lots of volume, we sat down and said, look, this is great. You're doing a lot of volume. But my administrator said, well, what kind of programs have you created to sustain this? How do you keep this going on a long-term basis? Because eventually you're going to say, look, I don't want to be doing this however many procedures a year. You want to say these are programs that work on their own, they're self-sufficient, and they're financially responsible. And I think that's where we make a very big difference between doing procedures and making programs, such as incident lung programs, lung cancer screening, valve programs, all of these different kind of platforms that not only will allow you to do procedures, but frankly, 10, 15 years down the line, they will evolve and grow into something that's very useful, no matter who's doing the procedures, whether it be 3 physicians, 1 physician. That's really what's important in organizing a lung health program. Go to that next slide. So this is, in terms of how do we optimize this space, really what we want to understand is, what are our goals? Now, there's nothing wrong with being a high volume program. But again, the same pitfalls occur if you're not looking at a strategic plan down the road. It's easy to look at the number of RVUs you're doing per year, but you want to look at how many programs you have in that large lung health program after 5, after 6, after 7 years. And frankly, how do you have a multidisciplinary approach to that, right? Someone living on an island by themselves doing either thoracic surgery, interventional pulmonology, without actually interacting in a sustainable and productive manner with oncology, interventional radiology, general pulmonology, all of these things, if you live and work by yourself, you're never going to develop that program. So your program is not really made up of one type of physician. Your program is, the way you look at it, is an institute of multiple different physicians from different specialties, whether it be oncology, thoracic surgery, interventional radiology, okay, and pulmonary. So really what we talk about is, how do we develop services and programs rather than doing regular volume. Technology is a very important part of this. Do you want to be one of those programs that is going to just stick to what you were taught in training and programs and training programs, or do you want to be pushing the envelope and getting new technologies, trialing new technologies, and being part of the group of individuals collecting data and developing that, which is a very important part of whether you want to be in a purely academic setting or a community setting. Again, this really, the barriers between academic and community are very much, blurred nowadays, in the sense that there are these hybrid programs, which are honestly where we learn a lot of our own data and a lot of the information for what we see as optimal programs. It's much easier to organize a hybrid program in a lot of ways that shares both academic and community aspects, as opposed to sticking to one or another. Now, a big part of this is personnel. A lot of people will say you can make structure and implement structure, but it doesn't always mean you get success with structure. A lot of it comes down to the individuals that you put into your program and select and how that grows. So do you end up having lung navigators? Lung navigators, although they're an FTE and they don't develop a certain amount of productivity on an individual basis, they are invaluable in terms of organizing your program, making sure things run smoothly, and frankly, making sure the I's are dotted and the T's are crossed. Are respiratory therapists involved in your procedures versus nurses? It really is dependent on your institution, but again, it's a dependency not only on skill level, but also on direct costs associated with that. Physician assistant and nurse practitioners, again, this is kind of also dependent on your institution and whether you're going to be helped on the floor or an outpatient. A lot of people think about a program being in the outpatient setting, but very rarely are we just in the Bronx suite or in the OR as an outpatient. It bleeds into the actual inpatient setting, and that's part of your program as well. And one last person in terms of personnel, which I know that both Greg and Bill understand, is there has to be an administrative champion, right? Doing this and working uphill and trying to fight administration on this is never going to result in productivity or growth of a program. One more last slide I wanted to go over, and this is kind of a pretty important to me in terms of how we organize this. Programs need to be financially sustainable. And I think that the idea of financially sustainable, people think about, oh, well, we have to be making money and we have to look at downstream revenue. That's not the case. A lot of what we have to do is look at how we use the same language as our administrators, meaning being able to talk to them about cost, looking at contribution margins, not focusing only on the downstream revenue, because frankly, that can be hard to track, especially in a community setting. What we need to be able to do as not only a group of physicians, but as a specialty and honestly as a service when it comes to lung programs, is be able to track what we do, how we do it, and what the direct cost and what the profit of that is. Not because we want to be able to pat ourselves on the back. It's mainly because to get what we want, we have to be able to justify ourselves financially to help take care of patients, right? And I think that's where we've lacked in the past, and only recently are we really understanding that we need to sit down in the C-suite and have discussions with our administrators and have regular meetings and assessments of our finances for programmatic growth, and also to gauge how we're doing, not only just on a clinical level, but also on a financial level. And I think that both Greg and Bill will talk about really, they've had to think about this. It's not just one of those situations anymore where we say, oh, well, I want this kind of program, or I want to build a lung nodule program. You have to be able to show your administration why we're doing it to improve clinically, but also how we can sustain it into the future. So first, I'm going to hand it over to Greg to talk about a variety of programs he's helped develop, but also kind of the background in terms of what he's been thinking and how he's moved forward with those from an incidental nodule perspective.
Thanks, Bobby. Can you hear me?
Yeah.
Okay, good. All right, hang on. Taking control. All right, so I'm going to spend the next 10, 15 minutes talking more about incidental lung nodules, but how it fits into the overall picture of lung nodule management and lung cancer management. And quick disclosures. So we start with the data. As we all know, lung cancer is really a disease that has a very poor 5-year survival rate, but not for all stages. And the whole reason we have a poor survival rate for the overall group of lung cancer is that the majority of these patients are diagnosed at late stage. And really the only way we're going to make a big difference on survival is going to be to impact that stage distribution that we see. And so if you look at your institution, I would recommend anybody who hasn't done this, take a look at what your institution or your state has for a stage distribution, because it's really compelling data. I've got 2 different graphs up here, pie charts. In Tennessee in 2012, I was in East Tennessee at that time, and we actually looked at one county within the state where we were located. 77% of those patients that got diagnosed with lung cancer in that year were stage 3 and stage 4. So we've already taken more than 3/4 of the patients and made them unresectable and basically incurable. So fast forward 7 years, I'm now out in Montana as of 2019. We looked at last year's data, and it's slightly better in Montana than Tennessee 7 years later, but still 67% are advanced stage disease. So we've got a real opportunity to make an impact on these patients. And what a lot of people do is they say, well, let's put a screening program together and that'll fix the problem. We'll find all of the cancers early and then all of those patients will be cured. The problem is, if you look at the data, lung cancer screening is only going to find about 13 to 15% of the lung nodules that actually get detected by your health system in a year. So if you couple that with the fact that every CT scan that gets done in your ER by your primary care physicians, anywhere in your health system, 25 to 30% of those scans are going to have a nodule detected. And if you think about it, it's very hard to make a stage shift if you only address 13% of the nodules that you're actually finding in your institution. And if you don't really address the incidental nodules, you can't actually avoid that dreaded question that I think all of us have had. I know I have multiple times over the years. Why didn't they find that lung cancer on my earlier CT scan from the ER? Well, the answer usually is they did, and they reported it, but nobody actually paid attention to the report. And so here you are 18 months later with your stage 4 disease. So I call this low-hanging fruit. These are incidental nodules that, you don't have to force somebody to go get the CT scan. They've already had it. The radiologist has already read the report. It's just that nothing gets done about the report in a lot of cases. So this is an easy one because the patients are already there and the data is already there sitting in front of you. So if you want to go after incidental nodules, what does it take to succeed? Bobby already said multidisciplinary and administrative buy-in. That's key. You can't really do this in silos, and you absolutely have to have your administration bought into the concept that this is going to be a win for the administration in the hospital. You're going to need manpower. Incidental nodule program is data intense. You are dealing with a large number of CT scans, a large number of patients, and they come in constantly. There's not a day that goes by that we don't get more data coming in that says, hey, there's more scans from last night from the ER. And so you're going to have manpower that's there consistently to manage that. You also have to have software to manage the data because you can't do it the old-fashioned way, reading the reports or trying to do it manually. You have to be able to screen radiology reports, and you have to manage data with computers in order to make this successful. And then you really need communication. It comes back to that multidisciplinary group of people who are all on the same page. You have to have the ability to really communicate very quickly and very easily between the different specialties. And as Bobby also said, if you don't really pay attention to your data and watch what's happening, you really are going to miss out on the opportunity to make a very successful program. So oversight and feedback are also a very important component. So what do you do if you want to go ahead? My suggestion is you determine your baseline data. You need to know where you're starting from. I showed you two different data points from. They're probably not a whole lot different anywhere else in the country unless you've had a program running for a while. But it's good to know where you're starting from. And it's also good to really look at what are your opportunities for improvement. What parts of your program are going to need some investment and some attention to make them work well. You need to add things before you start. You need to have whatever software you need. You need your manpower in place. You can't really just say we're going to start it and then we'll hire somebody because you'll never succeed. And then really the other question is, how are you going to implement a program like this? A lot of people say, well, let's just make it happen and we'll start on January 1st. I'll just tell you that in the last program I was in Tennessee before I came out to Montana, we were managing, or it was about a 280, 300 bed hospital. We had 5,000 CT scans to deal with per year and about 1,200 to 1,300 patients that we had to deal with per year just for the incidental program. It's best to do that as a phased approach. Build the program, build the structure. I usually recommend you use your screening patients, 13% of your overall volume. Make sure your database works, make sure all of your software is working properly before you throw this large volume of patients into the mix. And then you need to know what you're going to follow. And it's important to know what you're going to follow. And that's somewhat of a local environment decision. Also need to know what needs attention. Really good data points to follow, time to treatment. I've always argued that time to treatment is not time from diagnosis to treatment, which really only looks at your downstream physicians, your treatment physicians. It's actually when that CT scan was done until when they start treatment. Average time in the country, 120 days. 30 days is attainable, but you have to really pay attention to it. And then obviously we're looking for a stage shift. What needs attention? Physician service lines frequently need to be looked at. You're going to increase the volume for multiple different physicians in a hurry. And you need to make sure that you're in a position where your doctors are in place and ready to go, as well as advanced providers, all of the staff that you need so that you aren't overwhelmed right out of the gate. So how does it work? And there's not one right way. I'm just going to go quickly through what we do. The bottom line with incidentals is you're reliant on your radiologist. And when they identify a nodule, they put it in their dictation, and you've got a data point that can be computer screened. There are multiple ways to do it. Some places have said, well, let's just have the radiologist call somebody when they see a nodule, or let's have them flag their dictation with some special flag, and it'll go to the nodule program. That loses about 20% of the nodules that are detected by the radiologist because, to be honest, they're focusing on what the reason for the scan was. We see a lot of lung nodules detected by CTs of the abdomen, and they just mention it in the body of the text, but when it gets to impression time, they're talking about the things that they were looking specifically for or asked to look for. If you don't put it in the summary, it's unlikely that that's going to get flagged by the radiologist. So you use software and you can scan the entire text of the dictation and take anything that's out of the text, even if it's not in the impression. What we do is we scan for 10 different terms that are the different ways a radiologist will describe a lung nodule. And we get a report of any dictation that has any of those words. The navigator then takes the flag studies, removes the obvious false positives. The easiest false positives to remove is when the radiologist says no lung nodules. We try to get them not to do that, but they still do it. There are ways to make software work for that, but bottom line is we make sure that we get the false positives out. Anything that's easy to do by guidelines, the navigator takes care of. Anything that has to come to a physician to oversee, then we usually look at those, generally 2 to 3 times a week. Once it's identified, we guideline directed recommendations, and you can choose your guidelines. The 3 most common, ACCP, NCC, Fleischner, they vary dramatically as to how aggressive you want to be with an 8 millimeter or a 10 millimeter nodule. That's one where you get your multidisciplinary input, and with your group of physicians, what are you comfortable with, and try to pick a set of recommendations or guidelines that are appropriate for your institution. And then standardized communication pathways means you get that recommendation out to that ordering physician or the primary care physician. In the ER, it's not going to go to the ER doc, it's going to go to that patient's primary care physician. If we find something that needs an intervention right now, 5 centimeter lung mass, we're calling. We're calling the referring physician, we're calling the primary care doctor. If it's an ER patient who doesn't have a primary care physician, we see them all the time, we call the patient and try to get them in to be taken care of as quickly as possible. And then the rest of it is data management. Patients entered into the database. Database is mainly used to make sure they get their follow-up scans. If they're having, if they have a small nodule that needs continued watchful waiting, then that's the way we make sure they get their follow-up scans. It also gives us outcomes data for the whole program. And I know Bill will talk about this too. This is the perfect situation for a multidisciplinary clinic. It's really the most efficient way to do it, but it really does, it is dictated by your local environment. And then quickly, we could talk about this later, but basically quarterly review of your data. Make sure that what you are trying to accomplish is actually happening. Make sure that you address the patients who take twice as long as they should to actually get to the treatment phase, and give that feedback to all of your stakeholders. It's really important that all the physicians involved in this are actually aware of what's going on, because my favorite line is, build it and it will work does not work. If you just assume that what you put together is going to make it work just the right way, that doesn't happen in the real world. And so you really have to keep on top of your data to make sure what you're trying to accomplish is actually happening. And set your goals. And whatever your goals are, then you're going to watch them. Administration can set goals, physicians can set goals. There's ways to monitor all of this pretty easily. So what can it look like? The end goal is better patient outcomes, earlier diagnosis, more efficient multidisciplinary care. You will grow your practices probably faster than you're ready for if you put an incidental program in place, and increase revenue and market share for your administration. It's one of the few places in healthcare right now where all three win. The patient wins, the physicians win, and the administration of your hospital wins. So it's really, you do have to go out and sell it, but it's a positive for all different components. So just to go over some data real quick, this is actually some data that we just recently published out of our Tennessee experience. We published the outcomes of the first 2 years of an incidental and screening program. And over on the left side, third quarter was the first quarter that we actually did the program. You can see that within 3 months, we actually doubled our referrals to our nodule program. We increased our interventions, our procedures by 50%, and we also see an increase in lung cancers that were diagnosed. Kind of an added benefit was that our screening numbers started to go up as well. And I think it was just really, we didn't focus particularly on that. We were just so focused on dealing with all lung nodules. We did actually put a slide out for all the physicians in our health group that showed them how many screening scans they were doing and pointing out that they were missing a lot of opportunity. But, just focusing it into the primary care world increased all of that within really 3 months. Downstream also went up, and with the exception of our surgeons, we actually saw a drop in the later part of the first year. Our radiation docs and our chemotherapy docs were doubling their volume or more of patients per quarter. And a lot of that radiation I was in East Tennessee, heavy smoking area, lots of really bad emphysema. We were actually finding more stage 1 cancer, but they were non-surgical candidates, which means SBRT went up dramatically as well. And at the same time that treatment volume was going up, days to treatment, and this is days from their CT scan that detected their nodule to their actual start of treatment date, went down to under 30 days. And that was actually our goal. So did we get a stage shift? Yeah, we did. This slide doesn't project perfectly, but on the left was that same slide, 22% stage 1 and stage 2. After 1 year of the program, we went to 37% stage 1 and stage 2 disease. Year 2 didn't go up as much as we had hoped. It went to 39%, but was still moving in the right direction. So just putting that program into place really started to make a difference on what stages we were seeing. So one last slide, and this is just to point out my point about wanting to monitor your data and keep track of what's going on. you accomplish a goal and you say, well, our days to treatment are under 30, we don't have to worry about it anymore. Until the next quarter, it goes from 28 days to 42 days. And of course, my first answer was, well, that can't be right. There's no way somebody put the data in wrong. But when we dug into it, what it turned out was that we had overwhelmed our treatment side. Our radiation oncologists were so busy that they weren't actually able to get patients in for appointments or simulation in a timely fashion. It got them another radiation machine and more staff. But the thing is, if you just assume that it's all working properly, you miss that opportunity. And if you're monitoring your data, you can very easily go back and look at, what were the outliers, what patients were taking so long, and why were they taking so long. The other point I'll make about that is if you have a navigator, which you absolutely have to have, your navigator will tell you what the problem is before you actually look at the quarterly data. Because in this case, my navigator was hands-on with every single patient who was going through treatment. And she was telling me, a month before the data got finalized that we were going to have a problem because it was taking a long time to get him through radiation oncology. But, that's the reality is we start to build volume and then we're going to start to stretch the system capacity. And, the administration usually is really happy about having to buy more equipment because they're overwhelming their current equipment. It's one of the easier decisions they have to make as far as return on investment. And you can see we pushed that issue even back to administration, and it took us 2 quarters to accomplish it, but then the numbers were back down again. So it's just a plug to say, you really need to pay attention to your data once you get up and running to make sure that you keep it where you want it to be. And that's my last slide, except I'll give you a little touch of Montana. The Yellowstone River, which comes out of Yellowstone National Park, that's the largest free-flowing river in the United States, and that's my backyard. So that's all I got.
That's unbelievable. And I wholeheartedly 1000% agree with everything you said and how you set up your program. It's extraordinarily impressive. Those are the kind of outcomes you really are looking for. So would you nod your head and tell me if you can hear me? Okay. I'm really going to focus on about 3 or 4 slides, but I'll break it up into what's the problem when it comes to multidisciplinary care, what are the 2 models of multidisciplinary care, and what sort of outcomes should you expect if you really employ synchronous multidisciplinary care. So what's the problem? Well, time is survival in lung cancer. And time to diagnosis is too long. So recently reported by Peter Mazzoni, looking at the Lung-RADS registry, which are people who are doing lung cancer screening. They are our peers. Abnormal CT to diagnosis, 65 days. When we looked from abnormal CT to diagnosis 12 years ago at Wellstar, it was 63 days in the community. Diagnosis to treatment, so first the diagnosis, now we've got to get them to treatment, is increasing from 21 days to 29 days when you look at the National Cancer Database Review down at Cleveland Clinic. So if you add those 2 numbers, it's 94 days to go from an abnormal CT to treatment. Let's remember that, 94 days. All right, well, here's a survival slide. This was also reported out of Cleveland Clinic that there's a 13% reduction in survival if the time for treatment initiation exceeds 42 days. Well, wait a minute. We just said it was 94 days, 93 days. So that's 2 of these 42 days wrapped up in there. And so really the average is about 1.2 to 3.2% per week reduction in survival as you delay treatment. So Cleveland Clinic said their goal was to reduce their TTI to 20 days. Third issue, complexity. Lung cancer patients are complex, requires multiple specialists and multiple sources of real-time data. Because a group collaborates over the phone over time, does not imply that there's consensus in that plan during that treatment. All right. So multidisciplinary care. I would propose, assert that there are two kinds of multidisciplinary care, asynchronous and synchronous. And I'm going to show you these two models. You have a navigator. By golly, we have multidisciplinary care. So that navigator is armed with a telephone, and here's our patient in this red circle. So they have an abnormal CT scan. And where do they go? They're going to go straight to the pulmonologist. And that's our pulmonologist who receives the call and says, yeah, I'm busy over here taking care of these COVID patients. So I will see this patient in 9 or 10 days in the office. So they see the patient 9 or 10 days in the office, and they say, oh, you need a bronchoscopy, maybe an EBUS or something like that. So we're going to set it up for next week. So it's another week, and they get over here into the bronch suite. I don't know if you guys can see that. So we're in the bronch suite, and we do some EBUS, and we get some tissue, and maybe we get the mass. And they say, okay, I'm going to see you next week back in the office. All right, so we're about 2.5 weeks in. And we say, yep, you have a lung cancer, and it looks like it may involve the lymph nodes in the center of your chest. So we need to get you over to the medical oncologist. So we go over here to the medical oncologist. Yep, we can see you, and they're usually pretty good, 3, 5, 6, 7 days. So within a week, we see the medical oncologist. And I go, okay, well, I really need a PET scan. So let's get a PET scan, and I'll see you back in a week. Get a PET scan, see you back in a week. I think you need to see the radiation oncologist. So the navigator is setting up the appointment with the radiation oncologist. That takes another week. And the radiation oncologist says, nope, you're going to pass go here, and we're going to send you on over here to the thoracic surgeon. And those grumpy thoracic surgeons say, well, I'm really busy over here in the operating room, but I will see you in a couple of days. And we know statistically that's 63 days to 65 days to get to that point. Now we have a diagnosis, but we got to get to treatment, and time to initiate treatment can take another 29 days. We're looking at 94 days. You have a frazzled patient who's frustrated. How many office visits? How many phone calls? Now we're 3 months out. We got to repeat the CT scan. We may have to repeat the PET scan. PFTs are still in there, but we have multidisciplinary care managed asynchronously over 3 months by a navigator. It's okay. And I would call this the physician-centric model. We will get to you when I can get to you. Here is a synchronous multidisciplinary clinic. This is patient-centric. So this is our multidisciplinary clinic. This is the patient's CT scan. The patient is on the other side of that wall. First visit, this is with a CT. The navigator brings the patient with a CT, and here's my radiation oncologist. Here's actually a medical student who's happened to be with us. Here's my interventional pulmonologist, medical oncologist, navigator, and that's the grumpy thoracic surgeon. And we are all looking at the studies, and we go, you know what? I don't know. What's the best way to make this diagnosis? Mayfield, do you think you should do a wedge resection? Do you think you can get to this with the EBUS? What's the mediastinum look like? Is the patient currently on Eliquis? What's the plan? So we are going to create the plan together at that time. Tag, you're it. You're going to get the bronch done. You're going to get the EBUS done. We're going to get the PFTs done while they're in the bronch lab. And since we're 99% sure this is lung cancer, we're going to go ahead and get a PET scan if they'll let us do it. So we have one set of images and tests. You have one plan. And that plan is how we're going to get the diagnosis and staging in the next 7 days. The navigator said, okay, we're going to get on the phone. We're going to set up the PFTs. We're going to get the bronch done this week. All right. So here's the cycle. They come to see us on this Wednesday. Navigator brings her in. We just had that conference. We're going to have diagnosis and staging done within 7 days. And then they come back the following Wednesday, and we look at the studies. We look at the staging. We look at the lymph nodes. We look at the PET scan. We look at the PFTs. We all look at each other and go, okay, tag, you're it. This patient clearly is a stage 2 adenocarcinoma of the lung. PFTs look good. This is a lung resection. So Mayfield, tag, you're it. We're going to get the lung out this week. Or if the patient has a big mediastinal mass, Maybe they need radiation therapy, that kind of stuff. So the radiation oncologist, the medical oncologists get together and say, okay, who comes first? So, well, we're going to get a port put in this week. We're going to do the simulation for the radiation therapy, and I'm going to come up with my chemo plan. We're going to send the tissue off for biomarkers. By the end of the second week, the patient has initiated therapy. And that is a happy patient, not an unhappy patient. Now, these two patients, this patient, the one before, happen to live next door. They go to the same church, but or synagogue, but one of them is treated at one hospital, and the other is treated at the other hospital. This patient is through with their radiation therapy, chemotherapy, is already getting better, and the other patient doesn't have a diagnosis yet. There's a huge contrast between those two. So this is the process. The first week, we obtain tissue, PET scan, PFTs, MRI brain if necessary, insurance approvals. And then second week, we place the port, we get any additional imaging we need, radiation simulation, infusion, radiation starts. Really simple, straightforward cycle. Everybody's communicating. There's one plan, one time, one set of data. What's the barriers? Well, sometimes patients on Eliquis, it's going to take us 5 days before we can do the bronch and the EBUS and all that. Insurance approvals can be a challenge, but as you know, the vast majority of these patients are Medicare, so that's not an issue. And I can't tell you how many times a patient says, whoa, 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 whoa. I don't want to have all this stuff done. I want to go to Florida for a week first, and it kills our data. But, you know, it is what it is. I probably want to go to Florida too. And then the other on the treatment initiation, we're waiting, and I don't know what your experience is because we don't have a molecular lab. We're waiting for 2 weeks for biomarker testing from Foundation One, maybe a little bit more. We are now actually probably going to set up a molecular lab in our hospital. So what difference does it make? Well, we saw when we compared our data from 1999 to 2003, which was before we set up this multidisciplinary clinic, and then we set it up in around 2008, that we improved our survival rates in lung cancer through our care model, and that we exceeded the survival rates of the NCDB during those years. Now, let me put it this way. If Dr. Lemens and I invented a new chemotherapy drug that improved 5-year survival in stage 1 lung cancer by 13%, we'd be living in Bonaire right now. That would be a revolutionary treatment. Well, if we collectively are willing to improve our system of care in lung cancer to be patient-centric rather than physician-centric, we would improve survival by 13%. That would be revolutionary. So a synchronous multidisciplinary clinic improves survival, it reduces time to diagnosis, it reduces time to treatment, it vastly improves patient satisfaction, it reduces cost. You don't do all the doubling of the unnecessary tests, no unnecessary visits. It's the trifecta: faster, better, cheaper care. It's all the best. In an asynchronous model, we actually can demonstrate it impacts negatively survival. And that's shame on us. It increases the time to treatment, it reduces patient satisfaction, and increased cost. So that's it for us.
Guys, thank you so much. I mean, that's a lot of information, but really, honestly, exactly what we talked about at the beginning is that instead of organizing individuals, we're really putting together programs, like Greg is saying, and Bill. So, you know, I'm going to ask a few questions to get things going, but then we're also going to open to some questions from the audience. So, you know, I'll ask this to both of you, both Greg and Bill. You know, we talk about incidental lung nodule programs, and we then talk about the follow-up of those incidental lung nodule programs. A lot of times, what we end up saying when we try and put those programs in, how do we judge success, right? A lot of people think, oh, well, how many procedures did you do, right? In terms of how many diagnoses of lung cancers did you get, right? But we know that with these incidental lung nodules, only about 30% of them are actually managed appropriately, right? So, you know, I'll first of all ask Greg in terms of how do you guys, once you've gotten those lung nodule programs going, how are you measuring success in those programs? And then Bill, what I'll ask you is that really most of the nodules we see or the masses we even see, or stage 3 and 4 disease are incidentally found. It just goes through that asynchronous kind of path you talked about. So is there kind of a not only ability to develop these programs when it comes to incidental lung nodules, but also kind of plug them into that multidisciplinary approach as opposed to just a random lung nodule clinic where people get put in, they get seen, and then unfortunately go back into that asynchronous program. So Greg, in terms of how do you judge success, and then Bill, if you could jump in terms of how do you get those people to be synchronous as opposed to the asynchronous approach we're used to?
Well, Bobby, I would argue that if you try to judge your success by number of cases or even number of cancers that you diagnose, then you're not going to succeed and you're going to miss the main point. You know, what I put on my slide and what we set up as our main primary goals of what we were trying to accomplish is shortening the time to treatment, which means we have to have a very effective multidisciplinary program. And we want to see more stage 1 lung cancers and stage 2 lung cancers, which then translates to a better survival. So, you know, it's really, it really goes into Bill's patient-centric approach. Is what you really want to look for as your indicators for success is what's the patient experience and how are they, you know, how are you succeeding taking care of them? What you saw on the slides was that while we were doing that, we got more patients, we got more volume, we got more procedures, we got more cancers diagnosed, but more importantly, we got them diagnosed early and we got them treated timely. And that's really what you need to focus on.
Yep. Yeah, it's a stage shift.
Yeah.
So our lung cancer screening program, which has been running for the last 12 years, the multidisciplinary clinic and the screening program are set up at the same time, uses the multidisciplinary clinic, we call it the STAT clinic, Specialty Teams and Treatments, to manage the lung cancer screening nodules. So any lung RADS 3 or 4 is reviewed by our pulmonologists and or thoracic surgeons. They are in real time. And if there's any concern whatsoever, that patient is brought into the multidisciplinary clinic and that process starts. We are standing up the incidental nodule program in just a few weeks. And the model is exactly the same. It's going to be layered on with our multidisciplinary clinic. Our problem is we send 10,000 patients a year out of our hospitals and emergency rooms with undiagnosed pulmonary nodules. 10,000. So we're about to drink out of a fire hose. And we think we have the processes, you know, and the people set up because we've been doing screening for, 12 years, and we screen about 700 patients a month. So we're ready, but we're going to learn from you, Greg, and try to do a good job. But it is all tied into the same multidisciplinary process. There's no difference between the two.
So I'm gonna. Those are great answers, and I'm gonna ask a question that might get me in a little bit of trouble, but I think it's gonna make the most, improve the outcomes, and I think the plan for everyone on the call, and then we'll get on to some audience questions. But looking at identifying patients, getting them into the program, the patient experience, and then getting them into the synchronous kind of approach and multi-D clinic approach. What do you guys think is preferred for a new program starting up? An incidental lung nodule program to really focus on that, or a lung cancer screening clinic or program when it comes to kind of giving the most bang for your buck and understanding the resources and the benefits to the community?
The bang for your buck is going to come out of your incidental program, because just like Bill's going to drink from the fire hose, I mean, it does. The volume is really, more than what you realize. I look at it as they're all part of the same program, and you can use the same mechanisms that you use for an incidental program to manage your nodule patients within your institution. Because to be honest, if you have 100 different physicians ordering lung cancer screening and there's no central group of people, your multidisciplinary group or your nodule group, actually looking at that data, to be honest, we've actually, even this year, one of our first finds for our program now in Montana was a patient who had a follow-up scan for a nodule that was called unchanged. Turned out it was actually larger and it was metastatic prostate cancer. But if that didn't have oversight, that patient would have gotten another scan a year later. So it's, the way I look at this is if you're starting a program and you want to do a comprehensive program, build the structure to do your incidental program because that's where your volume is going to be. But do a trial run off your screening patients for a little while because it's a smaller volume and you can identify where your problems lie. Once you have it running really well, then open the floodgates for the incidentals and you'll be really well structured to actually take care of them because you'll have all the mechanisms in place. It's just that the volume is going to increase. And if if you can get the staff, if your administration says, hey, this is working really well, and you add your staff early, then you can handle it.
So my comments parallel that. So the incidental nodule program is business you already have. That scan's been done. It gets tagged electronically, and then that comes over to your multidisciplinary team. It's a larger volume than a lung screening program, but it's business you already have. It just comes to you electronically in a queue. The lung screening program is much harder to do. You have to go out to your primary care doctors. You have to sell them on it. The patient has to, go through the shared decision-making process. They go through the smoking cessation counseling. It's like trying to run through honey, getting one of those things started. So if you want a sort of an easy start, then the incidental nodule program, easier to do. It is just as important, in my opinion, to do a lung screening program. And the combination of the two, they're complementary to each other, and they should be using the same team and the same process. What you don't want is all your primary care docs out there and pulmonologists ordering lung cancer screens and managing those screens on their own. That's a huge amount of variability, drives up costs like crazy, and it's the reason CMS and USPSTF and MedCAC do not like lung cancer screening.
That's great. So I have a couple questions from the audience. One question is, Bill, why aren't we using these more patient-centric models in general in most care practices and hospitals?
Yeah, there's no compensation model for it. So physicians feel like when they're in their office, bam, 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 they can see patient after patient after patient. I don't know if it's every 15 minutes or whatever it is in medical office. They come to the STAC clinic. Then the pulmonologist, if we have 10 patients, the pulmonologist may see 4, medical oncologist may see 3, I may see 7, but it's slightly less efficient for the physician. They're not going to see a packed group of patients. I believe that because synchronous multidisciplinary care delivers greater value to the patient, you get a better outcome at a lower cost, that we should develop a comp model for that. And in fact, I am going to our medical group executives. Our WellStar medical group is about 1,300 docs. And I'm going to propose to them that there is a comp model that enhances the compensation for those folks who care for patients in these multidisciplinary clinics because they actually deliver greater value. I think once we do that, it'll populate, get out there. And that's been the major barrier.
Perfect. So another question coming from, a question about these multidisciplinary clinics, and I find it a little bit ironic. I'll tell you why. But in your synchronous multidisciplinary programs, how do you avoid the loudest voice in the room phenomena and encourage open communication? I find this relatively ironic because it's Eric Folk saying that, who's usually the loudest person. But,
Yep.
It is what it is.
So I put a sign, when we started this thing about 13 years ago, I literally put a sign out the door because I had 2 competing pulmonary groups. I had 2 competing oncology groups. I had a thoracic surgeon and whoever else it was, radiation oncology in there from various places. And I put a sign out that says, leave your ego at the door. The patient is here. And I did that. And it just requires leadership. to be honest with you. Somebody needs to lead, somebody needs to set the tone, and somebody needs to sort of call the question to the loudest voice in the room now and then, even though they may be brilliant.
Yeah, ideally, your loudest voice in the room should not be the leader, obviously.
Correct.
You know, I think one of the things that we've always focused on with our programs is that we want guideline-directed therapy. And a lot of times that gets past the loudest voice in the room, because if you are all looking at the same guidelines, you're going to come up with the same solution. And, you know, sometimes as the leader, it's being that voice that says, okay, are we following what the NCCN recommends for this patient? And a lot of times that gets you away from the loudest voice wanting to do something that might not be guideline driven.
Yeah, you get to hold each other accountable for that kind of very disciplined care.
Are you guys right now, and again, one of our questions is looking at the use of liquid biopsies either prior to or during kind of these multidisciplinary programs where we say, should we be utilizing these and should we be sending them before tissue comes back, mainly because not only does it give us data, but also it might be much faster compared to when we have to send out these molecular tests.
Yeah. So can I enroll you as a participant in my investigator-initiated trial on circulating, tumor DNA and incidental nodules or lung cancer screening? We're going to we're opening a study where we're doing liquid biopsy at the time that a lung RADS 3 or 4 is detected, and then we're going to see what the first 200 of those look like and what the sensitivity and specificity of those biopsies, those liquid biopsies are, compared to what we do at pathology.
Yeah, I've used it some. I think one of the issues always is that the oncologist frequently will take that data, especially if you have a negative liquid biopsy result. The way I view them is they're very useful if they come back with a mutation, because then you've got your data early and you can go ahead with whatever your treatment plan is. When they're negative, they're not 100% correlating to your tissue mutation testing. And in general, especially in the environments now, the oncologist usually wants to be as sure as possible whether they have an actionable mutation. And so what I've seen them do is, even if we do a liquid biopsy and it comes back negative, then they want to wait for the tissue mutation testing anyway. So that's one of the roadblocks to using them. I've used them with limited success, I would say. I mean, we have had some where we've gotten the diagnosis that way and it let us be quicker to deciding on the treatment.
I envision 10 years from now, if we do it right, that we'll be using circulating tumor DNA at a very early stage, maybe even replacing radiology, for screening for lung cancers. But we just have to do the correlation study.
Sure. So I have a challenging question, but very relevant, especially when we're talking about development of these programs. And as also Bill talked about, the reimbursement model with these multi-D clinics. Whenever you put out a incidental nodule program, you're going to find nodules in patients who are either don't have a PCP or are uninsured coming through the ER. How have you guys been able to kind of organize that from a navigator standpoint, and then moving them through the system and making sure that they're not lost to follow up, or that they're getting the appropriate care they need despite whatever circumstances they might bring?
Well, that's obviously the one of the issues, and I think paralleling that is getting your buy-in from all your primary care physicians who may or may not want you to take the ball and run with it. And that's some of the legwork at the beginning of the program, to make as many of your physicians that you're going to interact with aware of what you're doing, why you're doing it, and how they're going to interact with you. Meaning, we're going to, send you a message through Epic, or we're going to send you a fax message to give you the information. I think one of the really difficult ones is the patients who are uninsured, or I think even more important in my current world in Montana is all of the people that come through our city to go skiing or go to Yellowstone, and they end up in our ER because they had trauma and they have a nodule, and they're going back to Kansas. And how are we going to make sure that that actually happens? And, that's the limitations of what we can do, but in those kind of cases, we go straight to the patient and we say, who's your doctor? This was found, it needs to be followed. Tell us who your primary care doctor is in Kansas, and we'll call them and we'll send them a copy of that scan. And, that's our obligation, because we're trying to make sure that nobody falls through the cracks. There's not one right equation to this. If you have a large health system that has a large primary care base that is part of your health system and you're all on the same EMR, well, that's easy, because then it's all electronic communication. In Tennessee, we actually went one step further and we said to our primary care guys after about 3 months, you know what, if you want us to stop waiting for you to send a consult for us to see this patient, just sign this automatic referral that we've got and we'll take care of it. We'll still notify you of everything, but we don't have to wait for you to do the referral. That worked. 98% of the primary care guys signed it. So all of a sudden we didn't have that roadblock. But, in the real world, a lot of these institutions you've got private practice, you've got competing institutions within the same city who you're going to cross over patients. And so you have to really develop, what I always view it as, is you develop an in-house method of communication and an outside method of communication, and you do the same thing every time.
Bill, I might ask you, I might jump in and get one more question out of you, mainly and interrupt you on this answer, because I've gotten this question multiple times. How did you get all the people from Multi-D Clinic in one place at one time? And was it with lunch, or was it with some kind of incentive? Because a lot of people have been asking, well, how the heck do we organize time and block them off to be all in one place to be able to review these CT scans and make these plans?
Yeah, the reality is that all of these different people are going to see all of these different patients at some point. Are they going to see them next week or the week after? So the message you go out there with is, guys, we're going to see these patients anyway. So number one, why don't we just put some time aside to see them together? Number two, actually, they do serve lunch, which is kind of cool. I didn't think about that. And third, you got to show them why. So you show them the slide deck that I just showed them. This is how bad we are. It's taking us 60, 90, 120 days, 2 PET scans, 4 CT scans, all this stuff to take care of these patients. Shame on us. You gotta shame them. So when we first started the stat clinics, we had no patients. Nobody was referring to us. So what I did was I took some of the patients that I was going to be seeing in my office that had pulmonary nodules, and I sent them over to the stat clinic. And we set it up on Wednesdays from 1 to 5. Well, you weren't going to sit there for 4 hours for 2 patients. So what we decided was we were going to schedule those patients at 4 o'clock. So we had those 2 patients come in at 4 o'clock on Wednesday. And so everybody got in with their office. We all showed up at 4 o'clock on Wednesday. And then about a month later, there was 3 patients. And then the word got out. We go to the primary care docs. But within 6 months, it was 10 patients. Now we're seeing 60 patients a week in 4 different clinics across our health system this way. And it's spread to brain cancer, and it's spread to breast cancer and prostate. So if you create a good model and demonstrate good leadership, and you're sensitive to people's time, and create a model where it's not too cumbersome on them, you can make it work.
Great, guys. I really appreciate everything you've brought out in this discussion. It's been a challenging discussion because these aren't easy questions to answer. So again, thank you very much. And I'm going to hand it over to Jody for the last word.
Yeah, thank you so much. What an outstanding call. Lots of rich learning, and I know questions we didn't even get a chance to answer here, but we so appreciate your interest and involvement. Want to share with you all that this call has been recorded, and so we will send out a follow-up note to let you know where the information will be stored so that you can go back and listen to it. If I'm sitting in your shoes, I'm thinking I want to share this presentation with those on my multidisciplinary team to let them understand and learn from some of the experts here as to how they've gone about this process, and realize it's complex but we got to start somewhere. And Medtronic is here to help you and partner with you and try to provide what tools and resources we can in the process. So again, I just wanted to say thank you again to Dr. Mahajan, Dr. Greg Lemens, and Dr. Bill Mayfield. Outstanding job from you all, taking time out of your day to do this. Really, really appreciate it. And as you all know, we're doing these calls once a month, so look forward to perhaps seeing you at the end of August for our next call on biopsy and visualization techniques. Thanks, everybody, and have a wonderful evening. Stay safe and stay healthy. Take care.
To all of you. Thank you, guys.
Thanks, everyone.
Thank you.